Candida auris. The threat due to Candida auris is because this colonizes our body very fast, especially the skin and nose. It from them they can transmit from one patient to another very easily, and it also contaminates the environment. Generally, we say that the yeast is usually in the moist surface, but Candida auris even can persist in case of the dry surface for weeks together. That's a big problem with Candida auris. It develops resistance very fast. We never knew that in case of fungi, the resistance can come up so quickly. And that is one of the major issue in case of Candida auris. Moreover, it's a hardy fungus. So, generally, until unless you have got very strong disinfectant, you cannot handle Candida auris. It produces serious infection, and on top of that, difficult to diagnose because we need something like either sequencing or multitop, which is not available in most of the centers. So Vitech system was not able to identify. So this was the big problem, and because of the resistance, the antifungal management is also a problem. This story started in 2009. There was one of a Japanese lady in the year, she has this particular fungus producing the infection. From that, Candida auris name in that. Now you just see within a decade across the globe, it spread like anything. And you see, this is about the USA data, which shows that the incidence is going up in such high proportion. So, first time amongst the Candida or amongst the fungi, this is the only fungus which have been put along with the bacterial urgent threat category, where we generally speak about the carbapenem resistance, and this is put into that category. In South America or Latin America, you see the entry came quite late, but once it entered, it had spread like anything. In case of Brazil, only thing is that they have got very good infection control practice, and because of that, when it entered first in the north part, we all experts together tried to decide that it should not go to Sao Paulo and Rio de Janeiro, most populated two cities. And till now, it's not there in Sao Paulo or Rio de Janeiro, but it is in case of the north part of the Brazil which is being there. So, Indian scenario is very worse. India, it is now considered to be an endemic fungus. Like MRSA, in our childhood, you have not heard the time. Usually, whenever there was a MRSA came, we used to close down complete ICU. That used to happen, especially in case of UK and Western world. They used to close it, the hospital even, and clean it so that MRSA should not enter. But now MRSA is everywhere. So same thing is happening, going to be in case of Candida auris. You see that when we did study way back in 2010, this particular study, or 2011, when we conducted multicentric study, that time we showed that Candida auris is existing in India, and we said that you should take care. It was at that time sixth ranking order, but when if you see now, nobody paid attention. In case of Delhi, Pune, in all the hospitals, in Candida auris is now first rank in order. If you see in their ICU, if you see in case of my yesterday's slide, I had told you that Dr. Shivaprakash conducted the study in 22 ICU, where he had shown that Candida auris is now second ranking in order, which has been there. During COVID time, you see that two ICUs, when it had been studied together, it had shown that Candida auris is around 42% of all Candida species. And this is last year we published this particular paper of 67 Indian ICU. 67 Indian ICU where it had shown whether it is in Klebsiella infection or even in case of the Candidemia, it is the first rank in order which have been there, and mortality is also very high. What about the pediatric population? Pediatric population, we published this paper long back where we have shown that the Candida auris was about 7th or 8th rank in order. But then you see that throughout India, they had started reporting, like Amrita in Kochi, they reported it. Then Ramchandra Institute in Chennai, they also reported in pediatric population. So when all these things were happening, we could convince Indian Council Medical Research that this is like in case of USA, put under urgent threat category, you should do something here. So at least there was some advisory which have been put in case of the Indian Council Medical Research, and they said that if you have Candida auris, please contact the reference center at PGI. And because of that, you see, throughout the country, people contacted us. At that time, we tried to prevent the Candida auris entry across the whole country. But you see that it was not possible because of such a large number of population in India. Throughout the country, you see Jaipur, Uttarakhand, Assam, Rajasthan, everywhere this report came about Candida auris. Now, this we discussed or I told about the clade. Genetically, the Candida auris are divided initially into four clades. And these four clades, they came up at the beginning in four different places. Why it had come up, where from it had come up, there are a lot of hypotheses are there. I am not going into those discussion. But it is interestingly came out in four different places and they were completely distinct. The clades were different. Now there are two more clades, fifth and sixth clades had come up. Fifth clades came from the Iran area and sixth clades came out in case of the Singapore, then it had been found in Bangladesh. Indian isolates, all are in case of clade 1. And the clade 1 has got, if you see, highest resistance. Whether it is in case of fluconazole, almost 100% resistance, Vori nearly 50% resistant, Pauline 30% resistant, even there is resistance coming up in case of the echinocandin. So this is the scenario which have been there. Clinical manifestation wise, other than Candida sepsis, it generally produces deep-seated infection. It is not seen in mucosal infection, whether it is in case of your thrush or any skin infection, it is generally not seen. It is seen all in deep-seated infection in case of Candida auris. Now, I am just discussing about the outbreaks and how the outbreaks are controlled. I am just taking three outbreaks. First outbreak which we had reported from PGI Chandigarh, you see that this was first patient who have been detected in trauma ICU. And within 4 days, what we found, all the patients get colonized. By the time we could really do anything in this aspect, Amrita Institute had published, they had shown that there were two clusters. In the first cluster, they came to learn about this Candida auris, and because of that, they could control the second cluster very well. In case of the Patna, there is also in pediatric and neonatal ICU, similar things have shown. And all these ICU data showed that it had colonized the hands of the healthcare worker as well as it contaminates the environment. So, to control this outbreak, how to go for it, it was the dedicated team which tried to do. Then there was a contact precaution which we have told how to take about it. And of course, the PPE and other things which is required had been employed. So the lesson learned from these outbreaks is that possibly we need some amount of advocacy so that it should be made a notifiable or reportable disease. Otherwise, we will not able to control Candida auris across our country. We should avoid equipment sharing. That is one of the important way of spreading in case of ICU. Third is we need to improve, of course, infection control practice and early reporting to the infection control team. These are the requirements. How we identify, if you see in case of the Vitek or even in case of those type of commercial system, they usually not able to identify Candida auris. It is in case of the Bruchert or Biomerus, Vitek or Malditov that or sequencing. But there are some claims now in case of the Vitek as well as in case of BCDI panel that they are able to identify Candida auris. But I have seen that there are several times people are mistaking by doing this way. So you may ask, I don't have Maldi. What I should do? Those who are microbiologists sitting here, if you have any yeast where there is no pseudohyphae, if it is growing at a higher temperature, start thinking, can it be Candida auris? If it is resistant to fluconazole, it would be definitely chances that more of Candida auris. So you should suspect this way. We developed one media, selective media, that you can also try. This has been published in Journal of Clinical Microbiology. This is YPD, that is yeast extract phosphate dextroagar, along with high concentration of salt as well as iron. When it had been put into 42 degrees centigrade incubation, it showed that selectively we can isolate or identify Candida auris. So these are the some methods which you can try. But all these methods, clinicians are not satisfied. Clinicians want to identify it as quickly as possible. So generally we do have in the lab chrome agar. Chrome agar has also improved. Now it has shown that consistently you can differentiate the color of Candida auris from others. But then, even then, clinicians feel that suppose I want no Candida auris in my ICU. So any patient who is being transferred from the other hospital and coming here, can we stop this Candida auris entry? So any of the patients who have been referred, we need to do the somehow picking whether there is colonization or not. Where it colonizes, mainly in case of the skin, the axilla, groin, these are the areas, and also it had been seen in the ears. So if we can do something, and for this there is now kits are available, especially in case of this PCR kit, which really identifies it within 1 to 1.5 hours. Yesterday, Dr. Rajiv Suman said about it that beta-D-glucan somehow in case of Candida auris is very poor. It is not helping us much in case of diagnosis of Candida auris. So how to combat this threat? How you can stop entry of Candida auris in your hospital, and which patient group develops, you must know about that part, and then you can possibly stop about it. So there are several studies, case control studies, which have been, even Dr. Shiva Prakash conducted one study. It had shown that any patient staying prolonged ICU, and generally they have mechanical intervention, whether it is ventilation, whether it is CVC, total parenteral nutrition, they generally suffer from it. So patient with sepsis in ICU undergoing invasive management for longer period of time, that is more likely think about Candida auris. As I was asking that, can you prevent it? So if we have to look into the people for colonization, because the high colonizer are high shaders. So you have to stop this particular Candida auris entry in this aspect. So these are the different kits which have now been available, and these are FDA approved and also European approved, and which can be used in case of identification of Candida auris. As I said, that the environment is very important issue. Sharing of the equipment should be stopped in this issue, otherwise you will not able to prevent Candida auris. There is, like in case of your NDM, where you try to look into the wastewater surveillance is one of the method, and this is also seen in case of USA. We had not done such study yet. Wastewater surveillance could look into where Candida auris or which hospital is having Candida auris. So you see that with this wastewater surveillance, they could identify in USA the places which have been there. And there was outbreak in Nevada where they could identify what is the source in this aspect. means which are the patient group, where it is happening, from wastewater surveillance which can be done. So prevention wise, prevention is the same simple basic rule that you have to stop contact precaution. That is the major basic rule. Second important thing is that in case of your disinfectant, you have to have stronger disinfectant. Generally, quaternary disinfectant does not help. So you have to either the hydrogen peroxide or EcoShield. Those are the things which are required if we have to stop this aspect. And hand hygiene, of course, is one of the important factor. But somehow, if you see, these are the different recommendation of environmental disinfection. But in case of one patient getting colonized, how to decolonize, there is no recommendation. We used to do the uh, usually chlorhexidine body wash, and it used to take months together before we could really decolonize the patient. So it's a big problem, anybody getting colonized for getting decolonization. And there is no recommendation of any of these different centers which they have recommended because we don't have any process to know about it. Regarding treatment, current recommendation is of course echinocandin is the first line of therapy, whether it is anidula, caspo, or mica, which can be given. Now possibly rezafungin. This is one of the drug where it had been found that once weekly you can give. This is coming up as a new echinocandin, which could be one of the best way of you. A major challenge in clinical management is that inadequate diagnosis and not performing antifungal susceptibility testing. Additional approaches, removal of the central venous catheter, ophthalmic examination, all this you can do about it because fundoscopic examination generally we don't say routinely should be done until unless the patient complains about it, or if there is uh, any patient who is immunosuppressed, candidemia persisting for a long time, then only you can do. So this is demanding close monitoring. This is a study Parikshit had published from Pune. This particular study has got one very important significance. There are a lot of things which they have looked into, but one thing is that they have looked into different varieties of echinocandin. Now you cannot avoid generics. There are so many generics are there. Only good thing which have shown that there is not much difference in case of efficacy about the about the generic compound in case of echinocandin. That's very important thing which they have shown. So these are the new drugs which are coming up in case of antifungal management. Uh, One is, as I have said, rezafungin. Ibex fungrave is one of the drugs which have been found to be very good in case of the resistant cases of Candida auris. Ibex fungrave already had come in case of the either vulvovaginal candidiasis use, or it had been used when a patient had to be because you can give orally. So when you want to step down the therapy in case of invasive candidiasis, Ibex fungrave has been used. Phosphomonazepix has also very useful. Somehow the orolapine is one of the very good drug in mycelial fungus which had not been found to be very good. So this is Ibex fungrave which have been found to be really very effective in lot of those resistant cases of echinocandin. Advantage is that both oral and intravenous available, but important thing is that like other echinocandin, it cannot penetrate the CNS. That is one of the major issue. Rezafungin, I said orally, weekly you can use this drug. There are some research which are showing that some other method of working with it. One of this is that this is in case of the HIV protease inhibitor, which can be combined, and it has shown at least in vitro study wise, it has got much better efficacy. Nanoparticle that had also shown to be some of the important studies are coming up in case of this Candida auris, especially in case of biofilm breaking by nanoparticle. So, friends, within this short time, what I try to tell you is that Candida auris is a very serious issue in critically ill patient. It has now in the first rank in order in case of the most of the ICU. Possibly we should make it a reportable disease if government of India agrees on this aspect. Here it's very interesting that this particular fungus is behaving like a bacterium which is not known in other fungus, developing resistance very fast, easily transmitted, cause outbreaks, resilient pathogen. Generally, the predisposing factor wise prolonged hospitalization is one of the important issue. And as much manipulation you do, the chance of Candida auris infection increases. In case of identification, as I've told you that if you have MALDI or sequencing, that is good. If you don't have MALDI, but I have told you how you can think about Candida auris, and that way you can try to identify, you can send to the reference center of those isolates for confirming about the Candida auris. This is uniformly in case of India resistant to fluconazole. Voriconazole resistance is coming up very strongly, and also echinocandin resistance. Infection control is the most important thing. Cross transmission, you have to stop it. That is the major factor which has been there. In case of the environment, generally don't share the equipment. That is very important. Even the this blood pressure cuff, it can also spread Candida auris from one person to another. So I don't know whether we should have blood pressure separately for each patient. It's very tough to have. But even blood pressure cuff can spread Candida auris colonization from one person to another. With this, thank you very much. If you have any question, because this is a very challenging particular infection, I'm very happy to know that in Kerala, still you don't have such a important in Candida auris. What is the scenario in Candida auris, Jacob? Very common. I heard yesterday somebody saying that we don't have so many number of Candida auris. So I was feeling that possibly Kerala has got a very good infection control practice, and that's the reason possibly they have less. Northeast it is much higher. You know, as I've told you that in case of the bloodstream amongst all East, in certain centers is the first ranking out. Very bad. Do we have the bread? Number of incidents per month? Yes.
Told us that
Oh, Mike is there.
we should decolonize the patient with octanoidine body wash.
You cannot put chlorine on the body. So you cannot use that. So you have to use something which is not damaging our body. But we tried with the chlorhexidine. We used to go on doing daily chlorhexidine body wash. And it takes a long time for getting decolonization. So there is still I don't have any strong recommendation of any practice for decolonization.
So about the BP cuffs, how do you recommend decolonization?
I said I don't know
Don't have.
what to say.
Okay.
Because this particular fungus is very peculiar in case of your yeast. Generally, we used to know that it goes along the moist surface. Dry surface is not having yeast. But this particular bug is staying on your carpet, staying everywhere. Even one of our ventilator, we tried so many ways to get out of Candida auris from the ventilator. We failed ultimately. We had to discard that ventilator. Such a costly equipment. So I'm saying you Candida auris is a major issue in case of ICU.
For Candida auris, because the purpose is to block the P glycoprotein, right, with atazanavir, which can enhance the activity of other antifungals. The same thing can be achieved by the fluconazole or voriconazole or any other azoles like prothioconazole is also a powerful blocker for P glycoprotein. So why atazanavir was used? And ritonavir is a very strong P glycoprotein inhibitor. Why it is not studied?
Tell us what are the mechanism of resistance in case of Candida auris? In case of the resistance, most important thing is the efflux pump.
Yeah.
Efflux pump is so strong in case of Candida auris, this is one factor.
So that is P glycoprotein. So atazanide was blocking that efflux pump and improve or the enhance the activity of
It's not a all or none situation, it's not like that. The ABC transporter, there are two things. One is the multiple facilitator and there is the ABC transporter. In ABC transporter, it is very strong. There are so many, and then each becomes a paper. Like uh, we tried to develop a group with Rajendra Prasad, who worked in JNU, Shiv Prakash, and also from the JNSAR, that is in Jawaharlal Nehru Institute at Bangalore. We did a lot of those different mechanism. Each mechanism is coming out something more. Like suppose in case of the lipid on the surface of it, Candida auris has got a separate different type of lipid program. So that is also developing resistance. So it's very peculiar. It's not a all or none phenomenon is not there. I don't think we have yet answered this question why Candida auris is developing resistance so fast. Because there is no plasmid. There is no transposon. Jumping gene is not there. But it is developing resistance within no time. So that is a big problem. So we try to resolve it. We all have published paper, but ultimately didn't help much in case of people because these are the mechanism has shown in that. Rajiv, you want to say this?
There's a chance of missing Canada auris because of the when you do substitution. You said we can misidentify. Can we over identify? Can we
Over identification, once I have seen that which was identified as Candida auris was not found to be Candida auris, but generally earlier Vitek has not Candida auris at all. Subhash Todi, who is from Calcutta, he said, Dada, there is a paper which have been published from or which have been shown in a conference from Assam. They showed there is an outbreak of Candida sec. I said Candida sec. I looked into it, which is found in the achar. Means in case of your mixture, which has been there is Candida sec. I said, why from achar it would spread like that? Now we realize that was Candida auris. It was misidentified as Candida sec. So our knowledge has completely changed when we came to know about this fungus. This was as identified in different names earlier. I showed you that there are so many names which are there.
पूरा उल्टा हो सकता है can we ल्यूसिटेनिया को कोर्स बोल सकते हैं can we identify ल्यूसिटेनिया कोर्स
No. Shiva. Can you use the mic?
Candida dubosimilani and Candida vulturna. So these things can be identified as Candida auris. But only thing is that thing can be differentiated only by sequencing. Even MALDI cannot differentiate it. So that is the over identification that can be done.
That is Himoloni and Candida dubosi. These are the certain group of agents. They are all similar. These are Candida vulturna is one of the fungus again is started in case of Southeast India outbreak situation. Though India has not so many isolate, but it had been seen in Malaysia quite high.
Considering them as auris, at least in the ICU settings.
Those are the again resistant fungus. Behavior wise, quite similar to Candida auris.
Yes, sir.
So whenever you are isolating those things also, you have to take precaution. Like in China, they have got very high incidence of those group of fungi. So they have similar, almost 50% in case of Candida auris and others. So they had taken in the same infection control practice to prevent this aspect. Otherwise, it is a problem.
Yes.
So I would say that any yeast which is not producing pseudohyphae, it is bigger than Candida glabrata. Usually Candida glabrata yeast is very small. It is bit those who are microbiologists, I'm trying to convince them. And if you see that they are fluconazole resistant, start thinking, can it be Candida auris? Can it be Candida auris? If you have got a higher temperature incubator, 42, you can identify it, Candida auris. So I know that it is a big problem. People don't have Maldi everybody.
When we say that this is the incidence in this hospital and all that, it misses a part of the picture. For example, in Jupiter, we do not have Candida auris. We have only cases which have come from other hospitals. Otherwise, we don't have.
So why don't you train the other? Why you don't have Candida auris? You
I
can.
don't know that why we don't have, but we have.
No. There
we are
must be
keeping
some.
our eyes and ears
Either you
open.
have got a better infection control practice,
I think that is
or
one
or
of the
something
reasons. And
that
even when one person has come from another hospital, we have never had an outbreak. There has been no further horizontal transmission. So something is working. I am pleasantly surprised. But this part is not captured in most lectures and in most papers, because we are not going to publish this at all. Whereas those like Gangaram would publish that we have so many. So
No. I'm saying, like,
what
suppose
I'm
in
trying to
Pune,
say is in Pune, like Dinanath has a
that's what-
huge number of cases, and Jupiter has no cases.
so either Dinanath has got too many patients,
Yes, they have too many patients.
and Jupiter has less number of patients.
Yes.
Infection control practice is much
are
better.
Totally different. Yes.
So
They
that may, but when I have presented that 67 ICU data, that's a more generalization
I
across
agree.
India.
That is true. So on one hand, we should not get totally alarmed by some figures of say a hospital like Gangaram or something like that. It's not true. There's huge amount of variation among hospitals even in the same city. Even in Hinduja, there was hardly any Candida auris. So there is a difference. We don't have Acinetobacter. We don't have it. That's what I'm trying to say.
So you see that this is all depending upon how you are doing infection control practice, how you are doing hand washing practice, because in case of PGI, multiple ICUs are there. Like in case of the respiratory ICU, our people are very sensitive to it, and really they just hand washing practice, they have improved like anything, and because of that there is hardly any infection which happen in that particular ICU. But same thing, you go to the other ICU, the main ICU, random. So please, if you can do somehow preventing contact transmission, it would be really useful. Second important thing which I was repeatedly trying to emphasize is that whenever a patient is referred from another ICU or referred from another hospital, that particular patient may carry Candida auris. You should be careful about it. That is one of the important factors which whether we can do like suppose this particular test only takes 90 minutes for diagnosing Candida auris. So you can take a swab and collect the axilla, groin and nares in a single swab and send it to the lab whether there is Candida auris is there or not. By that time you can keep the patient in one side of the ICU, and if it is free, then you keep the patient properly. So this is one way I felt in that, because in case of the Gangaram hospital, I said that why so much of Candida auris. What Prakash Shastri wanted to emphasize that they have got too many referrals. I said, why don't you improve infection control practice? Institute like PGI, it is very difficult to do it, because PGI has got, in case of outpatient, there are about 12,000 daily, and 12,000 patients coming into the outdoor. In case of your emergency, 150 bedded emergency, there are 600, 700 patients daily, which is being admitted. So there is really difficult for the contact precaution. But like as he has said, Jupiter, no Candida auris. At least this particular center, I am seeing so much clean and cleanliness is there. You possibly can stop it, Jacob. And auris.
So what's the cost of this rapid diagnostic kit in India?
It's not very expensive. I think it is coming around. How much, Shiva? You said $2 or something like that. 200 rupees per. 300 rupees. It's not very expensive. When you are using echinocandin of 12,000 rupees, it's something not so expensive. Okay, thank you. Any other question we can discuss later because we are already, no, we are maintaining time. No.
Thank you, sir, for a valuable and engaging session. It's giving me great pleasure to invite our second distinguished speaker to the session, Dr. Pradeep Bhattacharya, to the stage. Today, he will be sharing his insight on a topic of growing clinical concern, difficulty in managing candida infections. With the increasing incidence of antifungal resistance and diagnostic dilemmas, this talk promises to shed light on practical strategies and emerging therapies in candida management. Please join me in welcoming Dr. Pradeep Bhattacharya to the stage. Welcome, sir.
Thank you. So, since yesterday, I think you must be hearing so many things about Candida, and now the biggest thing about Candida is Candida auris. And just now you have listened in detail from none other than Dr. Arunalok Chakravarti. So that makes my job very easy because most of the things which I'll be talking, I think it is somewhere in your minds in some or other place. Okay, but let us try to get a revision rather. What I think most of the things, as I said, has come in some or other part of different presentations. So, difficulties in managing invasive candida infection. Now, if you look at this chart, was a recent review which came about these challenges what we face as far as candida is concerned. It is maybe related to epidemiology, it may be related to diagnosis, cost, mortality, treatment. Everywhere there is a problem. And mostly when we see about treatment part, because management we always consider that is the most important thing, and diagnosis, there are diagnostic dilemmas already we discussed, and I'll go into those also. Then prophylactic antifungal use, whether you should use it or not. Optimal treatment duration, that is a problem we do not know very well. Additional antifungal medicine penetration, because just now sir was talking that auris mostly settle into the deep tissues, whether we are able to reach to those places or not. Effectiveness in difficult cases, then antifungal resistance. So there are so many complexities, and kind of patients who get involved are mostly ICU patients, hematological patients. Then obviously breakthrough infections are also not a small thing as far as candida infections are concerned. Then deep tissue infection, intra-abdominal infection, and other challenging infections. So we'll see in 25 minutes how much we can cover. So invasive candidiasis, it is the most common fungal disease we all know in hospitals in high income countries. Its worldwide prevalence is almost 250,000 to 7 lakh people per year, with an incidence of 2 to 14 cases per 1 lakh population, and mortality rate is almost 40 to 55%. So our concern is mainly this mortality part. Infection is okay, but the kind of patients who gets involved and the amount of loss we see in as far as death is concerned, that is huge. And 5 pathogens, this has been described as, because these are the data which was basically from Western literature. So Candida albicans and N. glabrata necasomyces and Candida tropicalis, Candida parasilosis, then Pichia cutia vacilli, and causes most of these invasive Candida infections. And as now we discussed, auris is another worldwide problem which has started in 2009 from Japan. Antibiotics, immunosuppression, corticosteroids can cause Candida species overgrowth. So anything which suppresses the immune system has got direct relation with the overgrowth of Candida. And death rates have not improved. This is the most concerning thing, that it has not improved despite that health system and ICU advancements in recent decades. In last 20-25 years, we say we have advanced a lot as far as critical care managements are concerned, but death rate has not gone down. And the emergence of new antifungals and other drugs are continued, and similarly new funguses or Candida species are also growing in a similar manner. So early identification of candidemia and deep-seated candidiasis is difficult. So that is, whenever we do a culture, we see patients and we send it for investigation. It is basically the part of fungus which is there in the blood, but we cannot understand what is happening in the deep tissues once the fungus has gone into it. Biomarkers which we are using, they are all indirect markers, but the significance that remain very uncertain. Then multi-drug resistant species as Candida auris, glabrata, all those species are spreading worldwide. So, and there is a need for customized antifungal therapy due to heterogeneous host characteristics, large geographical diversity, and a species distribution, and the rate of resistance to antifungal medications. And the value of different treatment techniques, what we see is very unclear. So invasive candidiasis, it increases the risk of mortality, and that is why indirectly or directly significant economic burden as well on the community. Now, what are our concerns about mortality? Among hospital-acquired diseases, nosocomial candidiasis has the highest fatality rate, estimated to be 40 to 45%, 50% within 30 days of diagnosis. And one study which was done in Europe, they said that 30 days mortality rate of 29 patients per 79 diagnosed cases daily. So you can imagine those invasive candidiasis can kill at what a faster rate. So in the past 2 decades, the mortality rate associated with invasive candidiasis has changed marginally, but overall, if you see, it remains almost the same. If you look at this chart, it shows from, this is a 25 years chart, and from 1993 to 2018, you can see that all kinds of drug which has been used, whether it is fluconazole, amphotericin B, other whether it is echinocandin, all those drugs have been used. But look at the mortality. Can you say that it is declining or it is increasing or something like that? Very heterogeneous chart. It is difficult to interpret. But when we look at the average, almost the 50% mortality is there across this last 25 years. It has not come down. Okay. Now, what are the concerns about diagnosis? Blood culture demonstrate about sensitivity of 63 to 83% for candidemia in absence of deep-seated candidiasis, and 21 to 71% in its presence, means deep-seated candidiasis. So an overall sensitivity is just 50%. So how much we can rely on it? So the sensitivity of Candida species may be influenced by previous antifungal treatment, prolonged turnaround time. Then obviously there are certain species of which are difficult to identify, could hinder the prompt commencement of antifungal therapy, because what happens once, like in blood culture, as soon as the patient gets infected, usually we can identify those organisms in the blood in 24 hours. But as far as fungus is concerned, Candida is concerned, the Candida itself takes 24 to 48 hours to come into the blood. So by the time, as it is advised in Surviving Sepsis campaign, that you should take the culture sample within 24 hours as soon as the patient comes. It doesn't help in Candida infection. It helps in bacterial infection because the species is not identified in the blood in 24 to 48 hours time. After that, it comes to the blood, and that is another reason why it is difficult to identify. Then non-culture diagnostic techniques should ideally serve as a complement to the culture methods what we are using. Now, the non-culture diagnostic tests have a varying degree of sensitivity, and there have been recent calls for the studies for further assessment of role of combination testing. So now a fashion is coming of the combination testing of Manan and anti-Manan assays together combined were shown to achieve a sensitivity of approximately more than or equal to 80%. Similarly, a combined use of biomarkers, that means a beta 1,3 beta D glucan and Manan and anti-Manan. Simultaneously, you do all the three things, and it has also shown a promising good sensitivity as far as detection is concerned. So, combination diagnosis, at one time you do two or three diagnostics and you try to get something. Now, what are the limitations of this? Uh, the indirect tests what we do, culture already we discussed. So there are problems with this Manan and anti-Manan tests. Serial determinations are required. Then secondly, lower utility of immunosuppressed host, may not distinguish between past and acute infection. This is very important. Then decreased specificity if candida colonization is present, and then low positive predictive value, and then the most important that they are not approved by FDA, and that not universally available also. Similarly, if you look at CAGTA, not approved by FDA, not universally available, may not distinguish between past and acute infections. Sensitivity varies according to the Candida species. As far as beta D glucan is concerned, again, serial determinations are required. Sensitivity varies according to the Candida species, may not distinguish between past and acute infection, not a species specific and requiring further tests to identify the fungus, and again, not universally available. So, there are a lot of limitations with all these indirect tests. As far as PCR, which is nowadays has become a very important way. They say this is one of the best way. Probably in future it will come. Data interpretation and that gets impaired by heterogeneity, and cost is a big concern which is associated with these tests. So overall, if you look, there are so many limitations with those all those indirect tests which we are doing in Candida, and they can be considered as important difficulties. Now, concerns about risk scoring. Once upon a time, I think 10, 15 years down the line, there was a fashion of doing this scoring. We also started doing it, but it was very cumbersome. Doing in ICU, it is not so easy. But again, when it was assessed, it was found that they have got more of high negative predictive value rather than positive predictive value. And the use of this Candida score largely debated and not validated for all populations. While this risk was shown to have sensitivity and specificity for invasive Candida of 81 to 74% respectively, the population most tested were from the surgical side. So that is why its validity on medical patients is very very low, and that is almost 35%. So that is why again, with such a low sensitivity, it is most of us will think not to use it, rather than using, you will like to use indirect tests instead of this. And this was one of those studies which compared basically this beta D glucan test with risk factors, and they found that obviously beta D glucan is much more superior with when comparison with Candida scoring system to identify that whether this patient is infested with fungus or not. And advances in genetic polymorphism identification, that is one thing which is growing fast and may show promising results in future. And as I said, that risk scores, if it is combined with other indirect tests, then probably we can get a better diagnostic accuracy. Now, concerns about therapy. These are important because since most of these invasive candidiasis trials, they enroll patients who are having candidemia, means we enroll with a positive candida is there on the blood, and very few they examine the deep seated candidiasis. So that is a big problem because, as I said, it is difficult to identify the patients who are infested with deep seated candidiasis. So treatment guidelines are more applicable to candidemia patients. Whatever we have, it may or may not be applicable to patients who are having deep seated candidiasis. Then, variations in treatment from international guideline recommendations present a significant challenge. Now, guidelines are coming. We see that it is there. But what is the compliance? When we see that how much of us we are actually following guideline, at least in India, I know that even less than 50% of the people are actually following the guidelines that what we need to do in these situations. So that is why internationally also study has been done, and they say that approximately half of the prescriptions have been evaluated as inappropriate because they are not following the guidelines. So this is a big limitation. Then, as far as initiation is concerned, early initiation of antifungal therapy has been shown to reduce hospital mortality, but requires starting antifungal therapy within 24 hours of taking blood culture. So, as candida species generally take, as I said, it takes more than 24 hours time to go to the blood. It is very difficult to identify candida if the blood sample is taken within 24 hours. So, that is why empirically the drugs are started, and that is how the practice of empirical therapy in fungal infections has come up, because most of us we fail to identify these fungus in the blood. Now the question about duration of antifungal therapy. Length of antifungal therapy is typically determined by the degree of organ involvement. And yes, CMID advises the treatment for candidemia should persist for 14 days following the last negative blood culture, and this is what is written in most of the guidelines. Additionally, it is suggested that organ involvement be assessed through transesophageal echocardiography or fundoscopy if there are some problem in the heart or somewhere. In contrast, now it has been shown that rapid diagnostic tests have been the potential to facilitate the timely cessation or de-escalation of empirical antifungal therapy. Retrospective data indicate that T2 Candida panel performs, if we do, as I said, it requires repeated testing of these. If we do it on repeated basis, it acts better than beta glucan, and when used in conjunction with blood culture, it reduces the duration of empiric antifungal therapy. So this is important. This is again a new thing, probably which will get matured in coming time, future. So then TDM is important. Yesterday we were discussing about TDM, and it is utilized basically for voriconazole 5, all azoles and flucytosine and posaconazole. But in critically ill patients, it is not only the drug which drives you to do this TDM, but there are other conditions like if the patient is on CRRT, treatment failure, breakthrough infection, severe toxicity, or candida infection caused by a species with elevated MIC. All these are conditions where it is now said that you need to do TDM. You need to do TDM. So, other than it is not only driven by the type of drug which we are using, but also the clinical condition and the kind of treatment which we are providing to the patient, that also drives the TDM monitoring. Then Candida auris minas, I am not going to that because just now sir has said everything in detail. Then drug dosing difficulty. Dosing and PKPD are also crucial during CRRT and extracorporeal ECMO therapy. We know with different classes of antifungals, and yesterday I told you that what happens when we use CRRT or ECMO, there are certain drugs which has been trial and it has been shown that their doses needs to be enhanced or increased during these therapies. So that is why the difficulty, this drug dosing difficulty is an important thing. And this is uh, a chart which shows that how the dose needs to be modified in different situations of different drugs, fluconazole, voriconazole, anidulafungin, based on mechanism of action and what are their recommendation in CRRT patients. So most of them, they you will see that usually it has needed an enhancement of the dose which we are normally using rather than what we are normally using. Now come to some specific conditions like intra-abdominal candidiasis. This is an important part of candida infection. These are very virulent kind of infection, as you all know, and the distinction between sepsis and septic shock usually made on usually generic criteria. So by looking at the clinical criteria, it is very difficult to say that whether the patient has got abdominal candidiasis or not. So excessive treatment of abdominal colonization, especially post-operatively, it increases fungal resistance. So aggressively, most of the time what happens, at least in my center I have seen, whenever there is a secondary or tertiary kind of infection, antifungal drug, it continues for months. I don't know, many times they say it is we get some culture positive, many times we do not get, but still empirically people go on giving, especially in surgical departments. And outstanding clinical challenges in intra-abdominal candidiasis include prophylactic use of fluconazole, the need of source control, and consideration for treatment of selection and duration. Diagnostic difficulties, then what are the problem with CNS infections? These diagnostic difficulties, because CSF cultures are the primary diagnostic tools. They have got a low sensitivity and can have several days to yield the results. So these are the problems and are not yet standardized. So that is also another thing. Then drug penetration. We know that echinocandins do not penetrate the central nervous system, and which are the first line choice for candidiasis. So we have again limitations for the kind of drug which should be used. High morbidity and mortality. Morbidity is most important because we know that after CNS infection, the patient may develop hydrocephalus, brain abscess, vascular events, and they may stay vegetative for a long time. So these are big problems. Then what about urinary tract infection? Yesterday, case was also presented. We also discussed that obviously the penetration of most of the drugs are very poor, and hardly we have amphotericin B, fluconazole and flucytosine. These are the three drugs on which we play. And secondly, what we need is to remove the devices whatever they are in the urinary tract implanted. So those are the ways how we see as far as urinary tract infection of candida is concerned. Now, management, as I said, device removal, you already have discussed. Then candida pneumonia. Yesterday we were discussing the prevalence is very low, almost 0.23 to 0.4% with increased risk linked to genetic predisposition and severe immunodeficiency. So it never develops unless until the patient has got a genetic predisposition and or severe immunodeficiency. Now the problem is that all those tests which we do, they cannot say that yes, candida patient has developed candida pneumonia, and ultimately, as yesterday we are discussing, that it is the biopsy which will only tell that the patient is having candida pneumonia. Other all tests are not reliable. So candida pneumonia lacks unambiguous diagnostic criteria. Unlike some bacterial pneumonia, clinical signs, radiographs, positive respiratory cultures are suggestive. Bowel fluid, including candida and inflammatory markers, are difficult to interpret and may vary from institution to institution. So there is no best antifungal drug or conventional treatment duration for candida pneumonia. This is also a problem. What drug has to be given? It is not yet decided. Which will work, whether it will go penetrate, work or not, we do not know. We have very less experience as far as Candida pneumonia is concerned. About Candida endocarditis, less than 2% of all infective endocarditis are because of Candida. And overall, the prognosis is very poor, and 1 year mortality is more than 50%, with the substantial relapse rates are also there. For diagnosing this, a high degree of suspicions are required, because clinically, when you see that patients are not responding to whatever recommended antibiotics are there, that you have to create a suspicion that yes, probably this patient is having Candida vegetations in the heart valves. So, Candida endocarditis, yesterday we had a discussion on this, and TEE is one of the methodology through which we can visualize the vegetations, and then accordingly we can mark the treatment. So what was discussed yesterday also, that we need to give at least 6 weeks of therapy, but how long this therapy should continue. But it has been shown that yes, long term as well maintenance therapies are required after giving 6 to 8 weeks of active therapy to these patients. So eradicating the infections from valvular tissue can be very much challenging, and prolonged treatment duration increases the risk of drug related toxicities and complications. So these are the problems, and high rate of complications. And surgical intervention is another way through which you can remove the heart valves, and accordingly you can, after that you give the medications, antifungal treatment. These cases require multidisciplinary approaches. Cardiologists, infectious disease intensivists, and cardiac surgeons should, all of them should be involved to manage such kind of cases. So, key challenges in managing Candida infections include insufficient global epidemiological data. Currently available diagnostic tools and risk scoring tools are inadequately address the diverse patient populations. The timing of antifungal therapy initiations remains critical, yet we do not know when to start, because most of the time we start it empirically. Echinocandins are recommended as first line treatment due to their efficacy, though they present higher costs compared to older agents. The efficacy data of echinocandins, cost effectiveness, and optimal transition protocol to azoles are limited. Despite emerging therapies, combination treatment are gaining traction in combating resistance. But I think combination therapies, good trial with combination therapies are still awaited. And addressing the challenges of early antifungal therapy and identifying the hideouts of infection will require ongoing innovation and treatment strategies. We need to do many research, many things in future to come to some good conclusions about all these questions. Thank you very much.
Pradeep, you talked about all cause mortality 40% in Candida. All cause. All cause.
But it how do you have, sir, any trial which suggests that mortality only because of Candida? Is
Yes,
it?
so that is an important question I want you to discuss further. So, what
uh,
is the attributable mortality to of Candida?
I don't have any idea about this.
No, in case of the unrecently data which we have studied,
In case of those 27 ICU, we found that 23% was the attributable mortality.
23%.
So attributable mortality was not that high as crude mortality. But again, I am saying
No,
23% is very high,
no, it is high.
but not 40.
No,
but not 40. Is the crude mortality is 40?
no, again, sir, the kind of case mix which has been included in these studies has to be taken into consideration. Because if we only see the cases of candidemia, only candidemia, and we say all cause or attributable mortality, that will give a different data. But if a patient is having candida CNS infection, candida valvular infection, candida, so those, if we have a case mix of all kinds of candida infection, then obviously the attributable mortality will be high.
See, the attributable mortality is a little different from all cause, because this patient who gets candidemia, he is already at a risk of very high mortality because of his underlying disease, and that disease may kill him rather than the
No,
candida
that is
killing him.
what I'm
So
saying.
these are very important issues. It's not very easy to just say that
No, but
all cause mortality and attributable mortality are far different.
no, I understand that, but in ICU it is very difficult to say. And whenever we say that yes, it is because of we focus on some one cause, and when we go on the background of the study and try to explore, we see there are lots of biases in calculating these.
No. I'm just trying to say both of you are discussing a different. Why I'm saying you are saying it's true. Candida endocarditis mortality is very high. Candida CNS infection mortality is very high. But what is the percentage of total invasive candidiasis are because of these two agents?
Overall.
So that is overall is if we look into whole invasive candidiasis aspect, it's mainly candida sepsis. And if you look into candida sepsis, what is the percentage of mortality? Again, I am saying 23% is very high. If you see in case of the Western world, somehow candida in invasive candidiasis, the mortality is falling, going down, or there is incidence is going down. The reason is much higher or much better infection control practice. Whereas mold infection is going up. That is there in case of the Western world. So India, I consider this is still very high mortality. We need to be careful.
See, a person has a seriously ill patient has both candida and carbapenem resistant Klebsiella in his blood. He dies. So what is the cause of his mortality?
No,
Is
I
it
understand.
attributable to candida
No,
or
no.
to the Klebsiella or
Obviously,
to
no.
both?
No, what you
So
are
we cannot separate it out very easily.
that is what I'm saying, no, sir. It is very difficult in intensive care patient to say that mortality because we say, okay, fluid challenge we have given in first 48 hours and we calculate 28 days mortality. That is absolutely wrong. That is not the way of, because that is why this we are moving from frequentist style of doing statistics in clinical research to Bayesian style, because in critical care people are moving toward Bayesian style because that puts some belief on the statistical calculation, because we see that okay, we have put a PEEP, the patient has improved his oxygenation, but we say, okay, what happened on 28 days? He dies, or he has died because of some other cause. But because he was enrolled in that trial, we say that
PEEP has killed him.
mortality is. So these are big problem with the trials, sir. Actually, yes.
So regarding duration of therapy, you said that those candida panels may assist in helping the duration of therapy, but the panels do not look at the live organism, any bit of the DNA in that.
No, again, I say you cannot stick to one particular thing. You have to combine the things together. First is your patient. As an intensivist, I never see the labs. I always see my patient. I have sent many patients with candida positive on taking samples who are candida positive, and I find that probably it was colonization that has come from the laboratory. But my patient is fine. He's moving around. He's eating. He's doing everything. He's fit for discharge. So clinical criteria, laboratory criteria, imaging criteria, all those have to be included together before taking any decision. So as I said that T2 candida, this diagnostic tests, so they are evolving, and they say if they combined with some indirect, take a decision of de-escalating the therapy and considering for discharge.
Okay, thank you.
Yes.
Sir, this question is to Dr. Rajiv Soman.
Rajiv
Sir,
sir.
have you ever had to treat a real case of candida pneumonia?
No.
The thing is that because the moment the microbiologist sends in some report of candida, everyone is jumping into writing antifungals for patients.
Very sad.
Very sad part.
Very
It's actually one of the most abused antifungals.
Didn't I show you yesterday one case where it was melioidosis? but there was candida in the sputum. So they thought that's the cause of the community-acquired cavitary pneumonia. So it's as bad as that.
As Rajiv Soman sir is one of the most eminent micro doctors, I think we should stop treating candida in these lungs actually.
But, I mean, even a small person like me also doesn't have to say that. It's there everywhere. It's all written everywhere. There is no need. This point is not up for discussion.
See, the thing is that even if, it happens that suppose cell count is 0, means I am saying you induction chemotherapy cell count is 0, and BL sample shows confluent growth of candida. And clinician says, I'd like to, because this is a patient who is going to have candida. I said, you may think about giving antifungal because of your own decision, but don't give this therapy on the basis of there is a candida lung infection. Candida lung infection with the autopsy data, it had shown is a very, very, very rare situation.
0.23 to 0.4
So,
I saw
BL sample
percentage.
means bronchoalveolar lava sample showing confluent growth, patient is absolutely immune suppressed, then also don't think it is a candida lung infection. So, candida lung infection is a very rare situation. But always, clinicians think, okay, there is so much presence of candida, we should give the therapy. That's
Not all clinicians.
No, actually very fond of writing a kind of candida. That is wrong.
No, it's not a question for discussion. I mean, I'll be happy to miss the case of candida pneumonia in my life. I don't mind missing that case. Okay, but it's so rare. It's the other important thing is
basically this is so difficult to take out this particular concept out of the mind of the clinician, and also the microbiologist. Not only that, microbiologists also, they are very happy that there is a constant growth of candida, so they like to report it, and clinician is also happy to start antifungal on that basis. This, either of them are wrong.
the other issue is you get a feeling. You means not you, but that it's a eureka feeling. I have found a cause of the patient's problem. I need not look anywhere else. That is the bigger danger.
Sir, one more doubt, sir. Now, the name of the Canada species gets changing every few times. Lusitania, Dublinensis, Glaberata, everything has changed. So, as a clinician, so one thing, why do you change the name? And as a clinician, how does it affect me? Means I really don't make sense of the names keeping changing.
See, all these things happen because of the molecular biology. Molecular biology has started giving more genetic study of the organism. So, which was earlier thought that this is in this genus, now it has been placed in another genus. I know about the clinicians there, and on top of that, fungus have got two names. You know that they usually, one is that called sexual stage, one name, asexual stage, another name. So international taxonomy, they say enough is enough. You stop it, all this, and you should have one name. So then we started having one name. But this type of naming, and especially if somebody from Czechoslovakia identifies something and put his name, that becomes all the more difficult to really say what exactly is that. So these are the problem. But I am saying as a clinician, you need not have to bother. If you say Candida glabrata, I am very happy to know it's a Candida glabrata. But when you go for publication, then there is somebody go taxonomist, he says he doesn't know even the basic thing of microbiology. Then there is problem. Otherwise, you need not have to bother.
Also, why do you have to italicize all the names? It increases our job now making a PowerPoint presentation.
So one more question, last question I'd like to ask us. The dose of amphotericin B is whether it's liposomal or deoxychol. It's a huge range. Almost it can go from 3 to 7.
Yes.
So I, as a clinician, I am at the risk of either underdosing or overdose. If I'm using 3, I'm underdosing the patient. So how do you decide the dose of liposomal?
So there is nothing like below 3. Okay, so 3 is the starting dose for liposomal amphotericin B. One has to understand 2 3 things there. That this is you you know the amphotericin B is inside the liposome. So this liposome is delivered in close proximity to the fungus, okay, away from the mammalian cells, and therefore it is able to achieve that thing very well. Because it is selectively being delivered to the fungus and has less nephrotoxicity and other toxicity, you can go up on the dose. In other words, you can realize the full potential of this drug. So you are not realizing the full potential of the drug when you are giving 3 milligram per kilo. After all, what decides the dose? The ratio between its efficacy and its toxicity. You have to remain in that window. So here the window, the toxicity, it comes up at a much higher level. So you can push up the dose and achieve a better and better PK/PD index with the amphotericin B. And that is even more true if you are dealing with an organism like Candida auris, because Candida auris, while you have brought up this subject, I must tell you this. For Candida auris and amphotericin B, the PK/PD index which is desired, that means the C max over the MIC is 9, and for albicans it is only 5. So this is a fundamental difference between the two fungi. Okay, so if you have to ever use amphotericin B for auris, it has to be 5 milligram per kilo and never 3 milligram. This is a publication from LEPAC and Andes. It's a very good publication. You should have a look at it. Similarly, for CNS, you can go right up to 10 milligrams, but I have had occasion to use up to 7. Beyond that, the cost and everything else also becomes much higher. So this explains why the range is wide, because now this drug has, in a liposomal form, it becomes safer to use. That's why you are using a higher dose to get a better PK/PD index.
So what is the starting dose for you and then it is
3 is nothing below 3. And then if you have a very tight situation like a CNS situation, or as I said, Candida auris, or even for mucormycosis, try and push up the dose to 5 as far as possible.
One thing is that there is nothing called step up.
Hmm. That you
In case of liposomal amphotericin B, very first day, whatever the desired dose, you give them the very first. There is nothing called slow escalation.
no. That arunalog is a different aspect. So in the past, when it was deoxycholate which was being used, it used to be, over 2 or 3 days the dose was increased. That what Arunalok is saying is you should not do that. But whether you should give 5 on the first day or 3 on the first day, I mean, I would still use my clinical judgment for that. Another thing in mucormycosis, there is something like a tempo of the illness. So you can actually get a feeling that in some patients the tempo is very rapid. In those patients, surgery, everything should be done as soon as possible. Another issue is you have to saturate. See, because in mucormycosis there is going to be vascular thrombosis. So the drug which is administered through blood is not going to get delivered to the site of infection. So try and do that as soon as possible. Rather than again that dose escalation should not be done. Give the highest dose right in the beginning. So these are some of the things which tell you that you should give a high dose as much as possible. But maybe on the first day, instead of that, maybe 5 milligram on 7 can come a little bit later. But 1 milligram per kilo, then 2 milligram, that is out of question.
Similarly, in case of fluconazole, I don't know why you use 200.
No, correct.
Fluconazole should be 800.
Really.
Thank you, sir. Next, we have Dr. Rajiv Soman sir on the stage. He will be sharing his perspectives on recent progress in diagnosis and management of mold infection and how it influences my practice. Thank you, sir.
Can I have the first slide? Okay. So this topic, friends, I am reminded of Alice in Wonderland. Why? Because she's asking the Cheshire cat, what road do I take? So there the cat is saying, where are you going? So the Alice is answering, I don't know. Then with a mischievous grin, the cat says, then it does not matter. Any road will take you there. Okay, so in the wonderland of literature on invasive mold infections, you should also start off with a specific purpose or a specific patient in mind, because otherwise you are in a wonderland. You don't know what to review in half an hour and tell you that. So let me begin with this. Okay, so I start off with this case, and I think this point we have discussed yesterday, so I'll just go over quickly. So this is a man with an advanced cerebral glioblastoma, refractory to treatment, lot of steroids being received intermittently, and then he had respiratory symptoms and nodules with halos, also a lobar consolidation, suspected IPA as well as bacterial pneumonia. So it was difficult to do any more invasive procedures on him. So a tracheal aspirate uh, LFD was done. So that was positive. And then also a galactomannan was done from the same sample, which gave you a OD value of 2.48. So is any interpretation possible? Okay, because this is from a tracheal aspirate. Okay, it's a proximal airway sample. Can we have the AC, please? Band hai. Okay, so remember, I have been telling this from yesterday's many times that the diagnosis of IPA rests on three pillars, with the mycological test being one of them. So serum galactomannan has a very less sensitivity, so it could be just about 30-40%. That of BAL fluid exceeds 70 to 90%, but that needs an invasive procedure. Now that can be difficult in that because of the physiologic state of the patient. So the hypothesis is galactomannan testing of proximal airway samples. We are going to call this as PAS of either. So what are these proximal airway samples? Induced sputum, tracheal aspirate. They are non-invasive, they are convenient, have lower cost, and could perhaps yield acceptable results. So this is one paper from Korea. So that is performance of the galactomannan test for the diagnosis of invasive pulmonary using non-invasive proximal airway samples. So this was a small study, but they were a mixed group of patients, including COVID, including some who are neutropenic and so on. And what was found here is that the positive predictive value of this, of the serum, was only 32, but of proximal airway samples were in the region of 70%, although not as good as of BAL. And so they did a ROC analysis in which they found that the OD value of roughly 0.7 had the best performance in terms of sensitivity and specificity. So what it really means is that the sensitivity and specificity of PAS and BAL fluid were comparable. The positive predictive value of galactomannan from the proximal airway samples was better than from serum, although not as good as from the BAL. And also the negative predictive value was good. So if you have a negative sample from the proximal airways, probably you don't need to go in for a invasive procedure and BAL. That is what it means. How will I apply this to my practice? So we are always dealing with this problem of suboptimal sensitivity of serum galactomannan. In which group of patients? In non-neutropenic, ICUs, COPD, viral associated pulmonary aspergillosis, and liver disease. So in these patients where the serum sensitivity is poor, BAL fluid sampling is a must. However, many of these patients will have these problems like hypoxia, coagulopathy, and a risk of an invasive procedure. Possibly the patient who is not on ventilator will now go on a ventilator, and cost, all these would deter the bronchoscopy and BAL fluid examination. So PAS has also been shown to be useful in an earlier study, and this was a study by David Denning in the context of COVID-19, where he found that 1.4 tracheal aspirate galactomannan was also good enough. It's a small study, and also in the COVID-19 context. So there they looked at the ECMM guidelines looked at non-BAL uh, sampling of galactomannan. So this particular study, although retrospective and with small numbers, has a variety of at-risk patients and really builds up on this concept of using non-BAL samples and the reasonable PPV in the presence of host factors and the clinico-radiologic syndrome. So when the pre-test likelihood was 15%, and that was on the basis of these two, the radiology and the host factors, that can help initiate treatment. And as I said earlier, it's on now. It's on. The high negative predictive value can avoid unnecessary use of bulb. Okay, so now let's move to the next paper. Now, this is a child who had a pilocytic astrocytoma and was operated. So, this is a post neurosurgical meningitis. Okay, so now that is going to be a difficult diagnosis. So, this also tells you how difficult the whole thing is. So, some neurologist has thought of aseptic meningitis, then has thought of TB also, and so on. Now, this doesn't seem very reasonable, but this is what is done in practice. Post neurosurgical patients are also thought to have TB meningitis. So, finally, this patient had a PCR based diagnosis of Aspergillus teres, and the CSF galactomannan was 5.26. Okay, so when you cannot get the diagnosis very easily, is there a scope for doing galactomannan or even beta-glucan from the CSF? And probably the answer is yes. So this galactomannan detection in CSF showed a good diagnostic performance, and an OD value of 0.5 or even 2 gave you almost the same sensitivity specificity. Okay, so you can use maybe even 0.5 in this situation. So the conclusion of this author was that using galactomannan in CSF, cerebral aspergillosis can be diagnosed or virtually ruled out without the need for a cerebral biopsy. Okay, and when we say it is cerebral aspergillosis, I would also consider any other mold which is producing galactomannan and beta-glucan. Okay, not necessarily only aspergillosis, so maybe some others. So similarly, it's beta-glucan. Even that also showed a good cutoff point of 110 picograms per ml. Remember, in serum it is 80, whereas here it is 118. That showed a good performance characteristics. Now this was Aspergillus teres. Okay, so how do we treat teres somewhat differently from the other Aspergillus? Answer is yes. Teres does not, amphotericin B does not work for teres. And looking at this small study, this is an experimental study, but what it tells you is that for both flavus and teres, you need a higher PK/PD index of a drug such as isavuconazole. So to answer your question, you talked about amphotericin B. So you might want different PK/PD index for different organisms. So here also you need a different PK/PD index. So you need a higher level, in short, if you are dealing with organisms such as flavus or teres rather than fumigatus. Okay, so I can't tell you that okay immediately you jack up the dose, but keep that in mind that you may actually have to use a higher dose of isavuconazole, which I will argue that we should do it based on some of these. So here, if you use all these extrapolative calculations, you might find that you can use a higher dose of isavuconazole. And this was not a very recent one, but this was our poster. We showed that PK/PD rationale and efficacy of using isavuconazole treatment after failure of amphotericin B and posaconazole for COVID-associated chronic cranial mucormycosis. So what we did here was give higher doses, such as maybe 300 and sometimes even higher than that, to achieve trough levels of 5, 6, something like that. Now this drug has remarkably less toxicity. So even if you use doses which are slightly higher to get trough levels of in the range of 5 or so, it can still be tolerated very well, and it is likely to work when you are dealing with a problem such as cerebral mucormycosis, which is already refractory. So when you are dealing with a site of infection which is troublesome to treat, as well as a patient has refractory or recalcitrant disease is not responding to others, you have to really go all out and try to do whatever best you can. So this was a brief study of just 6 patients, but they were all refractory and could be managed by a higher dose. So taking all these papers into account, how will it how is it applicable in my practice? So the biopsy of a cerebral lesion is often not possible due to technical difficulties, coagulopathy, non-availability of consent. Okay, also various other things. So you need a biopsy because non-infectious causes, TB, nocardia, many others have to be thought of. So CSF, galactomannan and beta-D-glucan can be utilized in these kind of suspected CNS mold infections, and galactomannan in CSF can actually also be used for follow-up. Now PCR and next generation sequencing, like that was the one which gave you the diagnosis of Aspergillus teres. Nothing else had given you that diagnosis. They are powerful tools that promise to find, so to say, the needle in the haystack, but they are yet to be confidently integrated into practice. So, our as clinicians, our confidence in the result which comes up from MG, metagenomic next generation sequencing and all that is, I don't know what to say. It's like 50-50 at this moment. Sometimes they turn up with some very, very funny organisms which I've never had have been shown to produce human disease, and then sometimes it helps. So, we still want to get a handle on this. Very, very confusing, correct. So it indicates, there are lots of problems, like you are transporting your specimen from here to there, then maybe some contamination comes on the way and so on, and maybe their methods are also still not up to date, which can build a lot of confidence among clinicians, not yet. So although not standard practice, TDM guided higher doses of isavuconazole, for that matter even posaconazole, may be useful in difficult to treat CNS mold infections. Now let's look at this case and papers relevant to this. So this was a alcoholic liver disease, liver transplant. He visits Kumbh-like gatherings and Maros dubki in that water, so submerging his head in various water bodies, and he did it before as well as after transplant. Okay, maybe once to ask for blessings, once for thanking the whatever after the transplant, but this is what he did. And what did he get? He got ventriculitis, as you can see there. Then he got abscesses. He's got vasculitis. You can see this drop off of this middle cerebral artery. There are infarcts and everything. And what was found there was scedosporium. Okay, so this was the isolate was identified. Now here, to answer your question, Arunalok will tell us which of them is the teleomorph and which of them is the anamorph. So here it was called as scedosporium, here it is called as pseudoalescheria boydii, but both are the same. And then this was sent to Chandigarh, and these are the susceptibility, this is the susceptibility pattern of that. So now this particular agent has intense neurotropism, and there are lots of difficulties. I'm not going to dwell into too much, but this is a very good paper which tells you the pathogenetic aspects of it, how melanin protects it, how it sort of subverts the immune system, what is it which gives it neurotropism, and so on. So this is a good paper for you to review. But what more important for the clinician is how do we manage this? So again, we go back to this recently published ECMM, ISHAM, is it ISHAM or ECMM and American ASM guideline. So look at these two, Lomentospora and Scedosporium. So now Lomentospora happens to be the really very difficult one to treat. Fortunately, this one was Scedosporium or Pseudoalescheria. So here voriconazole, maybe alone, maybe with terbinafine, seems to be the first line treatment. And if you look at salvage treatment, again it is a combination of these 2 or 3 drugs which has been advised in this guideline. But again, that is telling you that we still don't have a very good drug for this Scedosporium, leave alone for Lomentospora, and therefore new drugs which are coming up, and this is another good paper for you to review, which tells you that olorofin, which we have been hearing about in the last couple of days, is probably a good drug for treatment of this. So what's the applicability of all this in my practice? So culture isolation, morphology, Malditov ID is essential to differentiate Lomentospora from Scedosporium, although there I recognize that there are morphological differences in terms of, the basal part is swollen or something in one of them in Lomentospora. But it is difficult. So you do need all these techniques to differentiate the two, because treatment is much more difficult for Lomentospora. Now, MICs of molds are helpful, and that's why we sent it to Chandigarh for that report. But the exact relevance is still not clear because there are no established breakpoints. So, finally, even if you get the MICs, you finally have to treat according to whatever is the guideline. Recommendations from global guidelines can be useful, and combination therapy may have some advantages. Certainly, better treatment is an unmet clinical need, and therefore, we are really eagerly awaiting the introduction of, say, olorofin, which offers great promise. Now, neurotropism and interference of the CNS defense by these fungal agents are now being better understood. So, the idea of understanding how it does all this, it's not more for you and me, but for researchers. So, they will be able to find out in some ways whether that can be interfered. So, there could be novel targets for drug development. Okay, similarly, we have this lady who she's had diabetes. It's a post-influenza IPA with Aspergillus fumigatus, along with invasive pulmonary mucormycosis with Cunningham. And this shows you the morphological features of Cunningham. So now this is an organism which is more difficult to treat. Hence, a combination of liposomal amphotericin B plus high dose posaconazole was used, followed by posaconazole alone. So, if you look at these, how do the various anti-mucor drugs perform for Cunningham? Okay, so there is a problem here. Amphotericin B, um, except for Cunningham, posaconazole MICs were reasonably okay, and isavuconazole MICs were very high. Okay, so it's the posaconazole seems to be the best drug for this. So again, it tells you that identification of that Mucorales genus and species is very important. This is another study which shows in vitro activity of isavuconazole and amphotericin B in association against Mucorales. Okay, for Cunningham-Ella Bartholacea, the effect is always indifferent, so there isn't much of a benefit of combining the two also. Okay, now this was a patient with CKD, had received a living related kidney transplant, developed invasive pulmonary mucormycosis due to this fungus called as Rhizopus homothalicus, and that was invading the liver, and so we needed good penetration both in the lung and the liver as well as efficacy. Now, if you see this, and there have been publications from Shiva Prakash as well and Aruna Lok, of course, which shows that this particular fungus has somewhat higher MICs. So, if you look at it, amphotericin B MIC is much higher as compared to other Rhizopus species, Lichthymia, and even Mucor. And for the azoles, it is comparatively better, whereas, so that was the issue. So, would you use a combination? Now, this area is extremely complex. So, let me just show you a couple of papers and then you can draw your own conclusions. So, this is called as CAF to the rescue, that is combination antifungal therapy for to the rescue, and it's telling you about the challenges of combination therapy in reducing mortality, morbidity. So, in neutropenic, see how complex and murky the whole issue is. In neutropenic mice with mucormycosis due to Rhizopus delamar and Mucor succinyloides, amphotericin B plus isavuconazole improved survival. Now, this is experimental. However, in the mice model of disseminated mucormycosis due to Rhizopus oryzae, liposomal ampho plus posaconazole did not improve outcomes. So, it's impossible for us to make any great sense out of all this. Okay, and therefore I am going to talk about this paper. I know Arunalok is a strong criticizer of this, but this is probably the only paper which at least talks about it. So here you have combination therapy, as I said, always has great uncertainties and there is no plausible reason for synergy. This has been thought of all the time because the azole is depleting the target for amphotericin B. But I will actually address this issue in the next slide. there has been no conclusive benefit of combo, although that has been used frequently. If you are using a combo, please remember that your result should be superior. You cannot say I am using two drugs and I am non-inferior to that one drug. That absolutely makes no sense. So you must demonstrate superiority. If you have to do that, you have to have a very large trial, which is not going to be easy, and it is really unlikely to be done. Maybe there was an opportunity of doing it in the context of COVID associated mucormycosis, but we let that pass. So the hypothesis is probably a systematic literature review may help. So this was a systematic literature review which was done over 22 years. Okay, so that is one strength of that, and a very large number of patients were described. Although there were some patients who were given surgery, others who did not. So again, among patients who underwent surgery, 47 of 125 died compared to 16 of 24 who did not undergo surgery. So here if you see those who underwent surgery had a lesser mortality. But always remember that those patients are selected for surgery who are perceived to be at reasonably good surgical risk, and therefore they are offered surgery. So there is an inherent bias here in favor of surgery. Okay, so those who did not undergo surgery were so sick that they were not offered surgery. So not a surprise that they died. And then we conclude that those who did not receive surgery died. So surgery is very helpful. So there is a lot of difficulty in making these conclusions. But in this paper, the least mortality was observed when amphotericin B plus the azole, and I think somebody discussed this yesterday, were given together rather than when the azole was added later, followed by all other treatment options. And yes, like Arunalok said yesterday, among them now, how many received surgery, did not receive surgery, was it CNS mucor, was it lung mucor, was it cutaneous mucor? I mean, there can be so many of these variables, it is impossible for anyone to make any conclusion out of it. But while we were saying that, if you are using an azole and amphotericin B, it might theoretically be antagonistic, I would submit to you that it might not be so. For example, amphotericin B works like a sponge. This blue thing that you are seeing there is the amphotericin B, and it extracts molecule after molecule of ergosterol from the membrane, and the fungus reacts to it by synthesizing ergosterol. So if you can block that synthesis by 14 alpha demethylase, then with an azole, then it is reasonable that the two might synergize and might explain why this blue bar is the smallest, mortality was the least when it was given in combination. So I don't think we have any kind of evidence which is better than this, and this is also not so satisfactory. Now, guidelines do not recommend combination treatment as there is no trial data. But remember that absence of benefit is not evidence of, no. So what am I saying? Absence of evidence of benefit is not evidence of absence. Combination has been used as salvage, but again, efficacy in salvage is also not a proof of superiority. So we are just at the starting point. We can't go anywhere further. If there is benefit, I will submit to you that it will be best realized in which patients? In those who are at the highest risk of poor outcome. So my take on this is that the role of the azole may be that of a supporting drug if there is going to be an interruption or termination of amphotericin B is needed, and also maybe to widen pathogen coverage, because as I showed you, there are some mucorales which may be resistant to one or the other antifungal agent. Okay, so in that sense, maybe a combination might be good in some cases at least. But as he said all the time, the outcome is determined by many other factors. So are we justified in only focusing our discussion on use of combination when there are many other things to do in mucor? Surgery and all the other ancillary management, adjuvant management is possibly far more important than merely focusing on combination. So I'll close by saying that there are many studies which are published. Some are real practice changers. But remember also that science advances by a series of small steps and very rarely by a single giant stride. Now, practice can definitely become out of date, without looking at the best current evidence. But also remember, practice can be tyrannized by inapplicable external evidence. So you have to be very sure what is being seen in that trial. Is my patient similar to that or in many ways different from that? So you have to search thoroughly while managing the case and apply all this what you read very, very judiciously. So I'll end with this plaque which is outside the Mayo Clinic library, and what it says is enter in to learn and go forth to serve. In other words, what it means is every time you see a patient, read up. Now maybe we don't go to library, but at least look on the at your phone, and again go back to the patient and try to see whether what you have read is really applicable to the patient. So this back and forth thing is going to be very important. Just seeing patients, not reviewing literature, only reviewing literature and not really applying it to your own patient in front of you, both are not really good ideas. Thank you. Yeah, exactly. No, it extracts. This is the newer explanation for its action. So it forms a sponge-like structure on the membrane, and from there it extracts the ergosterol and thus produces a hole. And also the molecule itself goes and lines the hole so that the hole doesn't get sealed, and then there is leakage of intracellular contents, which is ultimately going to. So the hole has to be produced, and that produces leakage of intracellular this. Very important. Yeah. Yeah. So oxidative burst, TNF alpha release, these are also very important mechanisms of action.
Only thing is that though you have recommended to do CSF for BL, CSF for galactomannan or CSF for beta-glucan, only thing is that I would say that this is still not completely well standardized.
Absolutely.
At least this should be known to these people.
Correct.
Because otherwise the people start thinking it's only in an exceptional situation where really you are not getting any diagnosis. So it is. So this is not yet acceptable standard. We are. There are multicentric study going
Correct.
on in this.
Yeah. See, many of these things are, not yet to find their way into guidelines. These are just recent papers, and some of them may be helpful if you are in a tight situation. If you have a situation, if your patient has a problem which can be easily answered by the guideline, then you need not look further. Okay, the guideline is answering all your questions. But these are cases where the guideline is not sufficient to answer your questions. So there has any recent paper been somewhat helpful? That is the whole purpose of this presentation.
Eastern side. In Kolkata, I have heard somebody was using it, but it is not clear that किसी को भी बताया था कि हम यूज करते हैं, लेकिन मेरे दिमाग में था वो.
Our sincere gratitude for the presentation, sir. It is my honor to invite Dr. Atul Patel sir to the stage. He will be addressing a topic of vital importance, need of therapeutic drug monitoring. As personalized medicine becomes increasingly central part patient care. Understanding when and how to apply drug monitoring is critical to achieving optimal therapeutic outcomes. Let us warmly welcome Dr. Atul Patel to enlighten us this critical subject.
So good morning, everyone, and I'm going to speak on the need for therapeutic drug monitoring. Like since last 1.5 days, we are discussing about the use of antifungals, and probably we are also emphasizing on the drug levels and the PKPD index that we should achieve to get a better the success rate. The what is TDM? TDM is a therapeutic drug monitoring, and it definitely helps in the management and it also improves the outcome. But the issue with the performing TDM is several fold. So we are going to discuss the what are the issues with the TDM and why we need a TDM, right? So why this is very important concern to us. The reason is that the antifungal drugs, especially the azoles, they have very high or the significant inter and the intra patients pharmacokinetics variability, and this is very important reasons in a clinical practice, which leads to either the toxicities of the antifungal agents or it may leads to the reduced outcome or increases the mortality in case of the treatment failure. If you are using the TDM guided the dose precision therapy, then it definitely improves the safety of your drugs that you are going to use to treat the patients. At the same time, it improves the efficacy of the antifungal agents. The another thing that we have also discussed since yesterday is that the azoles, because it is exclusively metabolized by the liver, and it also has an influence on the metabolisms of other drugs by inhibiting the cytochrome P450 system. So various enzymes which can be inhibited by these drugs, as well as it also reduces the activities of the P glycoprotein, and thereby it increases the exposure of the drugs which is used by P glycoprotein pathway or the P glycoprotein efflux pathway. So this is how like the azole drugs are involved in significant drug-drug interactions, and at the same time because they are also metabolized by the liver, the other drug which influences the cytochrome P450 system like rifampicin or the anticonvulsant drugs which induces the enzymes leads to the reductions of the azole drugs, so it will leads to the ultimately treatment failure. And the last important thing is that therapeutic drug monitoring is a key component of antifungal stewardship program, right? So what is a real world scenario about the therapeutic drug monitoring? So this antifungal drug TDM is highly underutilized, and I'll give you the examples from the two USA hospital. So in more than 1000 USA hospital, and this study was conducted between 2019 to 2021. The TDM was performed in 15.8% of eligible patients, right? So large number of the public hospitals, and the TDM was utilized in just 15% of the patients. And look at the academic hospital scenario. So they also did the similar study in 55 academic centers, and in these academic centers, only 41% of the patient received therapeutic drug monitoring for antifungal drugs. Right, so this is how like this topic is extremely important and it is being highly underutilized. Now we need to understand like which drug requires TDM, right? So there are two components here. One is the patient's scenario and the second is the drug pharmacokinetics. In general, if somebody asks me to like which drug requires TDM, I will say that the drug which has got a narrow therapeutic window, right? That drug requires a TDM. What I mean by the narrow therapeutic window is that the drug which has got the narrow window in the sense that the less level end up with the treatment failure, and the higher level, the lithium is a standard, lithium and the dioxins are the two classical examples of the drug which has got a narrow therapeutic window, right? So the level which is just higher than the therapeutic the inhibition leads to the toxicities. So the drug which has got the well-defined exposure and response relationship, and the classical example here would be the voriconazole. The drug which has got a substantial pharmacokinetics variability. So you must be aware about the complex absorptions of the itraconazole capsule version as well as the posaconazole version, right? So the drug which has got a substantial pharmacokinetics variability from the absorption to a metabolisms, and voriconazole here is a classical examples. The drug which has a potential, the metabolism is affected by the potential genetic polymorphism, and voriconazole is again here a good examples of genetic polymorphism related variations in the pharmacokinetics. Coming to the clinical scenario, so these are the pharmacokinetics related scenario, and the clinical scenario, the patient who has got either hepatic or the renal insufficiency. The reason is that we know that most of the drugs that we use to treat the patients are eliminated by either hepatic way or by the renal pathways. So those patients who has any abnormalities in either liver or the renal functions, that means that their metabolism and the excretion of the drug is hampered, and that can lead to the variation in their pharmacokinetics property. So when you are handling a patient who has either end stage renal disease or liver disease, probably this is a clinical scenario where you go for a therapeutic drug monitoring to reduces the risk of toxicities, at the same time reduces the chances of underdosing, because now you are calculating that this is creatinine clearance of the patients, and probably this patient will require this much dose, right? So that calculation may sometimes lead to the underdosing of the drug, and patients can have therapeutic failure. The patient who has extremes of age and the weight, right? So in a very obese patient where the BMI is more than 30, many a times like the weight-based dosage may lead to the toxicities of the drug, and the drug need to be administered by the ideal body weight per calculation. So the patient who is of extremes of age, either the pediatric patients or the elderly patients, probably requires therapeutic drug monitoring. The another important clinical scenario, I think all of you must have faced the scenario when you are doubting or the patient adherence, right? So and the absorption of the drug. So somebody who has a malabsorption and the patient is not responding despite you are prescribing a standard therapy. So here, when you want to assess the adherence of the patients, I think TDM is a very important tool. You just draw the blood, check for the drug levels, and if the drug level is 0, that means that patient is not consuming. And the patient who has a malabsorption, so here also like TDM will help that patient is not having appropriate proper absorption of the drug. The another important scenario, patient scenario would be like when you are treating organisms which has got probably a higher MIC, right? So Rajiv Soman has also discussed about the Mucorales species where you expect a very high MIC like Cunninghamella or Sarsenaloids where the MIC is very high. So in this situation, to achieve the PKPD parameters, probably you are dosing drug at a higher level and try to monitor the TDM and check for the PKPD parameters. And when patient is on polypharmacy and you are expecting drug-drug interactions, so here also like you need to monitor closely about your drug which is probably given to the patient who has a drug-drug interactions. Now coming to the antifungal agents, so for voriconazole, the TDM is highly recommended. So when you are selecting a voriconazole for the treatment of invasive mold infections, TDM is highly recommended because it has got a narrow therapeutic window. It has got a very high variability, intra and intra-patient variability because of genetic polymorphisms in CYP2C19, right? And it has got a significant drug-drug interactions with other drugs. So this is how like you have to check for the voriconazole level. The another important things that you should remember in the voriconazole PK is that it has got non-linear pharmacokinetics, meaning that if your patient is receiving voriconazole and the voriconazole trough level is either low and you need to adjust the dose of voriconazole by increasing the dose of voriconazole, right? When you have not achieved the TDM, the increasing the dose does not means that you are also achieving the increase in the level. So while increasing the dose from 200 to 300 milligram twice a day, it may happen that the trough level goes down, right? So if you are targeting 0.8, and now you are increasing to 300 milligram, it doesn't mean that from 0.8 it may go to 1.2 or 1.5. It may go down to 0.6 also. And this is because of the nonlinear pharmacokinetics in adults. But in pediatric patients, the voriconazole has a linear pharmacokinetics. Voriconazole has a significant food and the drug interactions. So ideally, it should be consumed on empty stomach. And if some patient is consuming it with the food, then the bioavailability of voriconazole is roughly decreased by 28%, right? And we know about the genetic polymorphism with CYP2C19. So this voriconazole is metabolized extensively by CYP2C19, but it also metabolized by CYP2C9. And when there is a genetic polymorphism and there is a low activity of CYP2C19, voriconazole may be metabolized by CYP3A4 system, right? So all these three enzymes are very important for voriconazole metabolism. So there are various studies which has been done for in the ethnicity and the polymorphism with CYP2C19, and by and large, the Asians are the poor metabolizers of voriconazole. So we probably may achieve very high trough levels of voriconazole. So which is the best time to draw a trough level? So ideally, like when you are initiating any patients on antifungal therapy, you have to wait till patients achieve steady state level. Meaning that once you start putting on antifungal therapy, there is a wide fluctuation in the drug level in initial few days before the patient achieves a steady state level of the drug during the 24 hours time. Right, so here I mean the voriconazole generally takes 5 to 7 days to achieve steady state level, but if you are using a loading dose, that is 6 milligram per kg on day 1 and 4 milligram per kg on day 2 onwards, then probably the steady state level will be achieved at the end of 5th day, right? So this is the best time to perform a TDM. So once you are adjusting the dose with either higher or the suboptimal the levels of the voriconazole, then every 48 hours you may perform TDM just to recheck whether the dose adjustment has led to any change in the therapeutic drug levels. The another important thing is that when patient requires the prolonged voriconazole therapy, you need to recheck voriconazole trough levels periodically. This is because like there are two important things which can happen. The patients might be not adhering to the instruction, or patients may slowly accumulating because voriconazole is also inhibitors of the CYP3A4. And if this enzyme is utilized by the voriconazole metabolism, then over a period of weeks to months, you may expect the rise in the voriconazole level. So when patient is on long-term voriconazole therapy, it is a good idea to recheck the voriconazole levels periodically. The general recommendation is that voriconazole level between 1 to 5.5 is good enough for the management of this patient. But for Asians, we have a special recommendation that the level beyond the 4 is generally associated with the toxicities in Asian patients, right? So we generally try to keep the voriconazole level below the 4, right? So 1 to 4. And for the treatment of Aspergillus infection, the expert recommends that generally you should keep voriconazole trough level more than 2. Right, so this is a recommendation. Now coming to the PKPD parameters, right? So since last 1.5 days, we are discussing the various PKPD parameters for antifungal agents and the fungal pathogens. So AUC-MIC of more than 25 is generally associated with the clinical efficacy and the survival against the Candida and the Aspergillus species for voriconazole, right? But remember that, I mean, voriconazole has a nonlinear pharmacokinetics. And in clinical practice, we cannot calculate AUC. It requires a complex the formula to calculate the AUC of the voriconazole. You need at least 2 levels, Cmax and the Cmin. So that is a trough level and the peak level. Plus you have to apply into one the formula where you can get the AUC. So it is very difficult and challenging for clinicians. So what we do, we look at the Cmin upon MIC, right? So Cmin upon MIC more than 2 generally correlates well with the clinical efficacy. And this is very easy for us. So Cmin is a trough level. So for example, if your Candida or the Aspergillus MIC is 0.5
and you are achieving the level of voriconazole of, say, for example, 2.5, then the level would be, the Cmin upon MIC would be 2.5 upon 0.5, right? So it is obviously more than 2. So probably you are achieving your PKPD parameter. So this is how, like, probably you can incorporate the TDM in along with the MIC value in your treatment patients. And there are several studies which says that if you are keeping a voriconazole level more than 1, it is associated with a good successful outcome. And this is a very old study where the trough level of more than 1 microgram was associated with the improved outcome or the better outcome in almost 90% of the patients, as compared to 54% of the patient who had a better outcome when the level is less than 1. Another important the things that you should remember for voriconazole TDM, especially for the critical care physician, is that when you are using voriconazole in your septic patients or the patient who has critical illness in ICU, the inflammation, the systemic inflammation leads to a down regulations of CYP2C19, meaning that the metabolism of voriconazole in presence of systemic inflammation goes down significantly, right? So and this is a simulator. So this is a voriconazole level 1, 2, and this 3 milligram per liter. So as the systemic inflammation goes up by increase in the CRP level from 50, 100, 150, 200, and 250, the voriconazole level in the same dose steadily goes up. And once the patients start recovering from the systemic inflammatory conditions or the septic shock, with the reduction in the systemic inflammation, the CYP2C19, which is downregulated, may return to a normal states, and it increases the metabolism of voriconazole. So there can be a wide fluctuations in the voriconazole level when you are treating a patient who has severe systemic inflammation. So you need frequent monitoring of voriconazole level, especially in ICU admitted patients with severe systemic inflammation. And this is another real study where the CRP level increases the levels of voriconazole, the same thing. Now coming to the voriconazole dosage in obese patient. So this is again a very good study which says that when the BMI is less than 25, so when you are giving a weight-based dosage, the patients achieves a good level. But when the BMI is exceeding 35, and if you are using the weight-based dosage, see here, this is actual body weight dosage, and the voriconazole level goes up significantly. But the same patients, when BMI is more than 35 and you are using ideal body weight or the adjusted body weight, then probably you are going to achieve the appropriate, the accepted levels of the voriconazole. That means that in overweight patients, probably you should use either ideal body weight or the actual body weight to dose the patients, right? So there are higher chances of the supratherapeutic voriconazole level when you are giving actual body weight dose for the voriconazole. So how do we manage the subtherapeutic levels of voriconazole? So whenever like you are getting a results of voriconazole level and it is less than 1, so the first and foremost important things that you should check is that whether patient is consuming these drugs properly or not, and what are the other drugs that patient is also consuming along with the voriconazole, right? So that can affect the levels. So food and the drugs should be checked properly. Try to correct those errors. If patients has a low dose, you may also consider dose more frequently rather than going for a 12-hourly. You may go for a 8-hourly dosage of voriconazole. You may add the drug which has got the inhibitory potentials on the CYP2C19 like omeprazole. Omeprazole is not only inhibits the CYP2C19, but it also compete with the voriconazole for its own metabolism with CYP2C19. So it displaces the voricanazole's metabolism and it increases the levels of voriconazole. So you may try adding omeprazole to improve the levels. You may discontinue the drug which induces the CYP450 system like rifampicin, carbamazepine, or other anti-epileptic drugs. And for adjusting the subtherapeutic dose, you may add the 100 milligram incremental dose. Remember, the voriconazole has a non-linear pharmacokinetics, right? So even after every adjustment, after 48 hours, like you have to repeat the TDM level and recheck whether you have achieved the desired levels of voriconazole or not. And consider alternative agents for those who are ultra rapid metabolizers, right? So if you are exceeding the dose, then try to use the alternative drugs like posaconazole or isavuconazole, right? Now coming to the another important drug, that is itraconazole. So itraconazole is also the absorption is highly variable, and it is also a non-linear pharmacokinetics. And we know that there are 3 different versions which are available to us. One is the suspension, probably it is not available in Indian market. The capsule is available and the Suba version is available, right? Superior bioavailability version. There are significant difference between all these 3 versions, and these are not interchangeable. So if you are using 200 milligram twice a day with suspension, it is not interchangeable with the capsule version or not with the Suba version, right? So again, if you are changing a formulation, you have to again do a TDM just to make sure that you are achieving the appropriate level. For capsule version, which is commonly available and most commonly used in the clinical practice, it should be consumed with the food, because acidic pH will increases the absorption, and you have to avoid the acid reducing substance. So any acid reducing substance like H2 blockers or the PPI will reduces the absorptions of itraconazole. And if you are adding the carbonated beverages like Coca-Cola, it also increases the absorptions of capsule version, right? But for Suba version, if you are administering it on empty stomach, it increases the bioavailability of Suba itraconazole. So this is exactly reverse from the capsule version. The solution has 30% higher bioavailability as compared to the standard capsule version, but the Suba version has 173% higher bioavailability as compared to the capsule version. So this is how like there is a significant difference between suspension, capsule and the Suba version. The benefit of the Suba version is that there is less interpatient's variability, because it slowly delivered the drug into the duodenum, and it achieves a more consistent level as compared to the capsule level. And the omeprazole, which is contraindicated for the capsule version, but it increases the itraconazole AUC by 22% when you are using a superior bioavailability versions of itraconazole. So this is how like you should understand the differences in the pharmacokinetics parameters of different formulations that is available to us. And it is distributed widely, so I am not going to discuss into the detail. Itraconazole is primarily metabolized by the CYP3A4. And remember the beauty of this drug, it is metabolized by the CYP3A4, but it is potent inhibitors of the CYP3A4. What does it mean? So its own metabolism it inhibits, right? So over a period of months, when you are especially when you are planning it for the endemic mycosis like histoplasma and the other fungal infections, what will happen? Like on the prolonged use of itraconazole, it inhibits the CYP3A4 and it inhibits its own metabolism. So over a period of weeks to months, the level of itraconazole goes up, and you have to monitor this very periodically, just to reduces the dose and to avoid the toxicity, long-term toxicities of itraconazole. So not only the itraconazole is the powerful inhibitors, but it first metabolite, that is hydroxyitraconazole, is also a powerful inhibitor of CYP3A4, and it is more powerful and as compared to the parent compound, that is itraconazole. And it is also active antifungal agent. So whenever we are doing a TDM for itraconazole, always we check for the itra as well as the hydroxyitra, and both are potent inhibitors of CYP3A4. Generally, like when you measure itraconazole as a TDM, the level of hydroxyitra is generally 1 to 1.5 times than the itraconazole level. So if your itra is 1, then you expect that hydroxyitra level would be 1.5. So total would be 2.5. The half-life is prolonged, so it is the elimination half-life is 20 hours after single 200 milligram dosage, and itraconazole accumulates slowly into the body. So TDM generally it takes 7 to 10 times 7 to 10 days for achieving a steady state level. So it takes longer time to achieve steady state level. And the levels more than 1 microgram is associated with the treatment success, right? So your target is to keep and achieve more than 1 milligram per liter. Like voriconazole, we do not have the level which is associated with the toxicities, but I told you that for a longer run, when you are using itraconazole for a longer time and the level is more than I think 5 microgram per ml, then you may end up with a pseudo hyperaldosteronism, where patients can have hypertension, hypokalemia, and profound systemic symptoms like fatigue, weakness, and other things, right? And this is just because of the pseudo hyperaldosteronism by the prolonged and higher exposures of itraconazole. Now coming to the another drug, that is posaconazole. For posaconazole, I will take you to the one case which is very interesting. We have treated during COVID time. So this is a 71 years male gentleman without comorbidities. So he do not have anything, no hypertension, no diabetes, and had COVID-19 illness in the mid-September of 2020. And his son was an ID doctor in United States and father was residing in Gujarat. So he received ICU care with BiPAP support. He also received remdesivir, steroid, tocilizumab, and the convalescent plasma along with the heparin and supportive care. He had an episodes of candidemia during his ICU stay with the COVID-19, and this candida was identified by Candida hemolini at some other center during this COVID-19 pneumonia, and he received 2 weeks of caspofungin therapy. And he complained of back pain while on treatment for candidemia, and MRI showed a psoas abscess, paravertebral and epidural collection at L445 vertebrodiscitis. The psoas abscess was aspirated at other center and it grew mucormycosis and no other bacterial or the fungal pathogens. So this is how like he came to us. So severe COVID-19, no comorbidities. He has received tocilizumab, steroids, and episodes of candidemia for which he has received caspofungin. But during therapy, he develops back pain. So this was his summary. So my clinical impression was that like because he has a candidemia, so very likely that candida should be responsible for vertebrodiscitis and the psoas abscess and the epidural collection, right? And this Candida hemolini, which was identified at other hospital, it could be a Candida auris. And Candida vertebrodiscitis is very common because he has documented episodes of candidemia. Mucormycosis is a possibility because he has received steroids, severe COVID-19. So that was a possibility. And generally, like mucor is not a colonizer or contamination, except it is a contamination from a collection site or from the lab, but it is highly unlikely, right? So whenever you are getting a mucormycosis either from the respiratory sample or from any other biological body sample, you cannot ignore. So I think we should respect that paravertebral abscess. Probably growing mucormycosis could be a pathogens there, right? So this is how like we have started doing workup of this patient. So we did the biopsy from the infected vertebra, and we have also drained the epidural collection because he has some compressions and the low limb symptoms. And to our surprise, the direct microscopy showed aseptate mycelia, culture grew Rhizopus species. Multitoph and gene sequencing identified as a Rhizopus microsporus. Drug susceptibility sent to Chandigarh showed very high MIC for amphotericin B, POSA, as well as the itraconazole. So all were 4. No treatment options. And histopathology also showed the invasive mucormycosis into the vertebrodiscitis area. So this is a challenge. Son is ID doctor in United States. So when we saw a direct microscopy, we have started him on 5 milligram per kg of liposomal amphotericin B, which was increased to 7.5 milligram per kg. After talking to Professor Anulaloke Chakravarti, he asked me to step up to the 10 milligram per kg. But he's 71 years gentleman, and we thought that we should begin with the 7.5. So this patient received another second surgical debridement with vertebral fixation at the end of 3 weeks of amphotericin. And repeat fungal workup at this time was negative. So we were a little bit assured and happy. So he completed 6 weeks of liposomal amphotericin B, 7.5 milligram per kg without toxicities. I have not interrupted dose for a single day. A nice gentleman. And we overlapped the therapy with tablet isavuconazole for last week. And we continued isavuconazole and supportive care, right? So after completion of total 8 weeks of antifungal therapy, that is 3 weeks of isavuconazole. So isavuconazole was overlapped for 1 week with amphotericin B. The patient requires third surgery because of some pain and loosening of some area. So another vertebral fixation was done, but this time tissue showed mucormycosis, same species. So we changed isavuconazole to posaconazole, and again liposomal amphotericin B, same dosage, like 7.5 milligram was added. And posaconazole trough level was done, which was 3.2 with standard 300 milligram dosage. Remember that the microporous, the MIC for POSA was 4. So what are the suggested PK/PD parameters for posaconazole for the treatment of mucormycosis and Aspergillus species? So by and large, like AUC MIC of 200 is good enough for treatment of Aspergillus species with posaconazole, and for Rhizopus oryzus, it is AUC MIC of 100 is good enough for management of mucormycosis because of Rhizopus oryzus. But here we have Rhizopus microsporus with very high MIC for POSA as well as for amphotericin B. So if I calculate my the Cmin upon MIC, the ratio of 5.8 is good enough for the treatment of mucormycosis, right? And that corresponds to the AUC MIC of 200. So Cmin MIC ratio of 5 to 8 is good enough. So my patients, the microsporus was MIC was 4, the POSA level was 3.2. So if I look at AUC MIC, it is just 0.8. So it is highly unfavorable for the successful outcome. So this is a timeline of his treatment. So day 0, we have started with the 5 milligram per kg, but once we have the identification and the susceptibility, we increased to 7.5. So total 6 week he has completed. The last week was overlapped with the posaconazole. The first debridement at 3 weeks, which showed a negative workup for the mucormycosis. And at 8 weeks, the second vertebral fixation, the culture was positive and showing mucormycosis. So we changed to the posaconazole, and again liposomal was added for 2 more weeks. Fortunately, this patient responded very well. He recovered completely, and we have stopped treatment at the end of 6 month time with the same posaconazole dosage. And this is what the Rajiv Saman has also highlighted, that you can use posaconazole in higher dose. And this is a very good study which was published, which says that in a patient who has either resistance Aspergillus infection, that is azole resistance Aspergillus infection, or the patient who has the pathogen which has got high MIC, right? So in this Dutch centers, what they did, they have used posaconazole to achieve the level more than 3. Right? So either with the standard dosage, or they have increased the dose of posaconazole to 400 or 300 milligram twice a day to keep the levels more than 3 microgram. And in this small case series, they achieved a very good successful outcome for azole resistance Aspergillus as well as for the treatment of mucormycosis and the fungal infection into the sanctuary sites. So all these 3 case scenario, probably they have done a good with keeping and achieving level 3 more than 3. Now coming to the question, why my patient responded, right? We did not do a great trick. 7.5 milligram of liposomal amphotericin B. Isavuconazole was a failure here. Unfortunately, like we could not check for the isavuconazole level during that time, because at that time during COVID period, we do not have an access to the isavuconazole level, but we do have posaconazole level. So the question comes, why this patient responded despite highly unfavorable PK/PD parameters? possible answer you may get from this study, and this is very interesting study. So even though like posaconazole is not achieving good levels into the plasma, but in this study what they check, they looked at the posaconazole level in the different compartments, right? So from plasma, red blood cells, polymorphs, and the PBMCs. And what they shown that when the patient level was checked into the plasma, at the same time into the inflammatory cells, the levels into the inflammatory cells is several fold higher as compared to the plasma, right? So plasma level is 603 the nanogram per ml. At the same time, the PBMC has 12,700 level. So this says that the posaconazole achieves a very high intracellular concentrations, and probably when there is a fungal infection, the area is infiltrated by all the inflammatory cells where you can get a very high posaconazole concentration, and probably this might be working. And they have also demonstrated there is a improved antifungal activity in both in vivo as well as in vitro in models of pulmonary aspergillosis in mouse model, right? So probably the POSA is achieving a very high intracellular level, and that might be a reason that why this patient is responding. This is what we did during the COVID time. We did a early day 4 TDM for all the COVID patients where we could not offer amphotericin B because it was not available. And we found that majority of the patients, they achieved more than 1.2 at day 4, right? So probably the capsule version is more consistent in achieving the therapeutic drug level as compared to the suspension. How do we adjust the dose when the POSA level is suboptimal? So what you can do, you can increase by 100 milligram incremental dose. So if your 300 milligram is suboptimum, give 400 milligram. But if you still need a dose adjustment, it is advisable to divide them into the 2 doses. So 12 hourly dosage is recommended. Now coming to the isavuconazole. The TDM for isavuconazole is not routinely recommended because it has got a linear pharmacokinetics just like fluconazole, right? For fluconazole also, like there are very few clinical scenario where you will go for a therapeutic drug monitoring. Similarly, the isavuconazole has a linear and reliable pharmacokinetics, while the rest of the drugs that we have discussed has non-linear and unreliable pharmacokinetics. So IDSA recommends that for progressive aspergillus infection and non-compliant patients where you also expect some absorption issue, you can go for isavuconazole TDM. But remember that in ICU, when patient is critically ill, there are higher chances that your patient with isavuconazole treatment has suboptimal isavuconazole exposure. So this is one scenario where probably you are going for isavuconazole TDM, right? The other factors like elevated BMI, higher SOFA score, and the presence of sepsis is associated with the lower isavuconazole exposure. So these are the very few clinical scenario where probably you are going to perform the isavuconazole level. And in scenario like my patients, ideally we should do and try to monitor your isavuconazole therapy. So this is a very interesting study which says that in clinical trial and in real world scenario, the patients are achieving almost same level, right? And this is why the routine isavuconazole TDM is not recommended. So this is clinical trial patients and this is the real world scenario. So mean and median is almost same, right? There is no much significant difference. So take home points from the TDM talk. I'm not going to discuss about the fluconazole and the 5-flucytosine. The TDM is highly underutilized in our clinical practice in patients management. So we need to improve the understanding and the acceptance of TDM in day-to-day clinical practice. TDM is highly recommended for the voriconazole treatment. The subitraconazole has markedly improved PK/PD parameters. So if your patient really need itraconazole therapy, that is a formulation of choice. The itraconazole and hydroxyitraconazole are strong inhibitors of CYP3A4, and when you are measuring itra level, try to monitor both the levels, right? And calculate the itraconazole exposure. The frequent TDM when patient is on prolonged itraconazole therapy is recommended because it inhibits its own metabolism, and you expect increase in the levels of ITRA and hydroxy ITRA over a period of time. The TDM helps in individualizing the patient's antifungal therapy, and it improves the patient's outcome and reduces the toxicities. For the POSA, TDM guided therapy helps clinicians to improve outcomes similar to the voriconazole therapy. And routine TDM is not required for isavuconazole, but there are clinical situations where probably you will go for it. TDM is also helpful in certain difficult to treat situations like the site of fungal infection, especially the sanctuary site. That study showed that sanctuary site, when you are using very high the levels of posaconazole, it works well. The fungal pathogens which has got higher MIC like Mucorales species, Scedosporium, Fusarium, where the MIC for azoles is generally high. The antifungal susceptibility results are showing the higher MIC for the antifungal, where TDM guided therapy with achieving the higher level probably helps you in managing these patients. And the other factors which potentially affects the pharmacokinetics like drug interaction, absorptions, patient is having end stage liver or the kidney disease, and the patient is having marked obesities. Thank you very much for the listening.
The groups remain the same, and the places also remain the same. We break for tea and we'll be back by 11:30.